So welcome to the last session of the seventh annual conference of the Saudi Society of Rheumatology, and I really appreciate your kind attendance and wait until the last session. The last session is going to be on musculoskeletal radiology for rheumatologists. Please join me to welcome the chairperson for the session. He doesn't need any introduction. My teacher, Professor Umar Fathuddin. He is a professor of medicine and rheumatology at King Abdulaziz University, and he's also a senior consultant rheumatologist in Jeddah City. He has published through his career numerous publications in the field of rheumatology. So welcome, Prof.
Bismillah ar-Rahman ar-Rahim, wassalatu wassalamu ala ashraf al-mursalin. Thank you for this very nice introduction. It's my pleasure to be sharing this session, which is the dessert session for rheumatologists. And I would like to thank the chair committee and organizing committee for this very nice conference. And it's my pleasure to present Dr. Khalid AlIsmail. He's a senior consultant radiologist. His main interest is musculoskeletal. He's going to update us and be an interactive session about radiology for the rheumatologist. So welcome, Dr. Khalid AlIsmail.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. حقيقة الواحد يخجل يوقف في الوقت هذا لأن الناس اللي حاضرين يعني يستاهلون زبدة الزبدة. فاي هوب انكم ان شاء الله تعالى تستفيدون لو حاجة واحدة من كل case will present. It will be a sort of case scenarios, and then we'll get until the diagnosis, inshallah ta'ala. This is the first case, which is the 45 years of age male, complaining of painful, palpable periangular lesion at the second finger. On examination, there is striated longitudinal nail marks, and they tried antibiotic, hasn't been efficient, and microbacterial culture is negative, normal labs, and then ended up with having ultrasound of the nail. So this is a normal appearance of nail ultrasound and also macrograph. The most important thing is that you know those structures which you are really looking at. If anybody speaks about the nails, striation, pitting, or dystrophic changes في النيل, على طول واحد يروح towards psoriatic disease. And it's very important, if you are really scanning that area, that you scan also adjacent regions which are really associated with psoriatic disease. If there is any abnormality, it will be appearing. So if you know that the nail bed, there is volar plate, dorsal plate, and also periangular region, in addition to distal interphalangeal joint. This is a normal patient. This is our patient. So what we are having now is that a mass lesion, like a hump, causing finger clubbing-like appearance, with increased Doppler ultrasound features. So there is increased vascularity. In addition to that, there is also, أنا ما أدري ما في pointer هذا ولا فيها, I'm not really sure. في أيوة هنا. Okay. Like this. صارت كبيرة شوية. Anyways. خلينا نضغط مرة ثانية. Okay. لا ما يضبط. Anyways. For what we are seeing now, that distal interphalangeal joint erosions, you can see it, the joint is narrowed, in addition to the extensor insertion of the extensor tendon, increased vascularity. That means there is evidence of enthesitis, which is the insertion of the tendon into a bone, is the enthesis. So now, mass lesion associated with nail changes, destruction at the distal interphalangeal joint. So what is this entity? We'll go further back to X-rays. There is evidence of periostitis, soft tissue swelling, mild narrowing of the joint space. MR, distal phalangeal edema, bone edema, that means periostitis, soft tissue edema, and evidence of volar aspect of the joint, which is covered by the flexor tendon insertion and extensor tendon insertion abnormality. So these both are involved. This is the category. It is called POPP. So it's very important to know this entity of disease. Psoriatic arthritis, everybody knows, but knowing psoriatic onycho or onycho pachydermoperiostosis is a thing which is really important to know. So this might be something which is great to know, because management might help in these cases, deviating from probably sort of traditional medications. Similar cases in literature. So you have these patients, this patient, the other patient is at the big toe, showing the same typical manifestation. Nails, changes, striation, distal interphalangeal joint involvement, the enthesitis, and soft tissue swelling. These are the characteristics of the POPP, psoriatic onychodermoperiostosis, pachydermoperiostosis. Third patient, the same thing. In the foot, big toe, the same problem. Same manifestations. Another patient, distal phalanx of the thumb and showing the similar manifestation. Dorsal insertion of the tendons. This patient has evidence of even the deep layer, which is the nail pit pathology, edema, with the periostitis or the osteitis. This is the same case. A third case with the big toe, okay, big toe, the same pathology. So this is POPP. Okay, this is another patient. So now all of them, they look the same typical manifestation. So if you have sort of these patients, think about POPP. So it is one of the subtypes of the psoriatic arthritis. The patient might show psoriatic skin lesions or might not show anything, but most of the cases would show these soft tissue enthesitis and soft tissue swelling. If you go and search about this disease in PubMed, until yesterday, there is only 31 cases has been reported. So it is rare disease or hasn't been categorized as this disease. Probably the other patients were not discovered to be POPP. So just think about this disease entity. So the key points here, that these 4 or 5 presentations of the, or typical presentations of this disease, you should just trigger towards this disease. Okay, any questions? It's an interactive session. Yes. The only differentiation is that this one is monoarticular. Mono. So most of the time it is affecting one digit. And it takes probably 1 or 2 years without knowing the exact diagnosis. If this, like this patient comes to us as a radiologist, and long time, or for one year or 2 years, swelling, or 5 months, we will think about one thing, which is post-traumatic changes. So I will think that this patient might have a trauma complicated with secondary degenerative change and then the soft tissue involvement. Or I will think about infection. It's similar to unilateral sacroiliitis. Unilateral sacroiliitis, I will think about infection, infection, infection. This is the same one. But having this with the either manifestations in the other joints to support the psoriatic disease, or that it will be only one to support this one. Association between psoriasis and this one is definitely from the name. Psoriasis should be part of the disease. So psoriatic pachydermoperiostosis, this is one of those, or onycho. Onycho, that means it is a nail. So pachydermoperiostosis or periostitis has effect on the bones, especially on pediatric age group or adult age group. If you have a patient with bilateral symmetrical periosteal reaction of long bones, think about pachydermoperiostosis. Pachydermoperiostosis characterized by thickening of the palms, sweating, and even the thickening of the forehead. This is typical manifestation of pachydermoperiostosis. So periostosis has diffuse systemic periostitis leading to bilateral symmetrical diffuse periosteal reaction. Okay?
About if sometimes you can see a patient with gout with podagra, for example, they have soft tissue swelling, they have erosion, they have periostitis. How can you differentiate between this and this POP?
Mumtaz. The gouty arthropathy, or what you call them as crystal deposition disease, they most of the time are associated with no significant bone loss or bone osteopenia, especially gout. There will be juxta-articular, bunched out, overhanging margin erosions في late phases. لكنه the bone marrow or bone density will not be changed. Number one. Number two, if you see enthesitis, this would support inflammatory arthritis, not the crystal deposition disease. So now you have enthesitis, insertions of the tendons, problems, and the gout arthropathy, this is not a feature. So you have these two things which might support and add your more power towards the POPP.
Doing MRI to confirm the difference?
MR, ultrasound can help definitely. Yes. The second case is 17 years of age patient with low back pain and hip pain. And this is common, like in a young patient. What is the most likely diagnosis out of these? How would you see? What is your diagnosis from this SI joint X-ray? So we have normal X-ray, we have osteoarthrosis, we have sacroiliitis, we have osteitis condensus ilii. D, OCD. The patient is male patient, young patient. C, okay. We'll see. Okay. Our evaluation for SI joint plane radiography for sacroiliitis, depending on which criteria, which assessment criteria. For sacroiliitis or for spondyloarthropathy, assessment of sacroiliitis, we have 4 categories. Number 1, modified New York classification. Number 2, AMOR classification. Number 3, European spondyloarthropathy working group. Number 4, ASAS classification. 3 of them, except the ASAS, they use the classification or criteria for the SI joint from plain films. ASAS goes with HLA-B27 and MRI examinations. So this is more towards ASAS. Now, we have 4 grades of sacroiliitis changes or sacroiliac joint changes. 0 is normal, no problem. 1 is doubtful, I'm not really sure. Is there any sclerosis or there is erosion? There is no erosion. Number 2 is erosions. Number 3, sclerosis and erosions. Number 4 is ankylosis or fusion. So how can we categorize this one? Which grade is it? If you say that it is sacroiliitis. So this one has definitely sclerosis at both sides of the SI joints, more towards the iliac aspects. There is mild irregularity and possible mild pseudo-widening. So if you have bilateral grade 2, this is definitive for sacroiliitis. If you have unilateral grade 3 and above, this is diagnostic for sacroiliitis. So this one is at least a grade 2 to 3, bilateral. So this is definitely sacroiliitis. Okay? So the answer is C. It's not easy as this. We'll go further. How can we differentiate between OCI, which is osteitis condensus ilii, and the sacroiliitis? Easy, simple. OCI, most of the time it is in females, multiparous, and the shape of the osteitis condensus ilii is a triangular shape. You can see them towards the iliac aspects, triangle, and towards the inferior aspect of this SI joint. So if you see triangle, shining, sclerotic, bilateral, this is OCI in a female patient. So this is the differentiation between sacroiliitis and the OCI. So this is bilateral. سمي تفضلي. Can be unilateral and can be bilateral asymmetrical. But common things are common. Bilaterality is more common. Yes. So this is bilateral sacroiliitis we agreed upon. From the history, this patient is HLA-B27 negative, has elevated ESR and CRP, normal white blood cells, has type of pain waxing and waning, and marginal response to non-steroidal anti-inflammatory medication. So is this typical for spondyloarthritis or not typical in a young patient? It's not really typical. We'll go further. We searched about this patient's folder in PACS. So he had this X-ray or X-rays and MR for the knee, which is showing metaphyseal or distal metaphyseal edema with fluids collection in the MRI of the distal femur. which was diagnosed at that time to be some sort of systemic disease. We'll go further. If you see such findings on MR, low T1, bright stare, or PD fat sat, that means it is edematous changes. Which one you will choose? JIA, which is juvenile idiopathic arthritis, or spondyloarthritis, or metabolic bone disease, or CNO/CRMO. أحد يعرف CRMO؟ إذن chronic recurrent multifocal osteomyelitis. Okay, what is CNO? Okay, هذه إن شاء الله تعالى إحنا نحتاج أن نتعلمها من هذا السيشن. Okay, so which one you will choose? D في شيء ثاني ما في spondyloarthritis مثلا bilateral sacroiliitis. That's okay. We'll choose D. ممتاز. Then what is further evaluation which has been performed to this patient? This patient had a disease around the shoulders bilaterally. He had also around the both lower limbs, which is about distal femur, with soft tissue edema, subperiosteal edema, or fluid collection. So he was diagnosed to have CRMO/CNO. This is an image from the literature showing the subperiosteal elevation or collection in a case of CRMO. So CNO is مثل ما قال الدكتور chronic non-bacterial osteomyelitis, وهذا المصطلح اللي نبي نتعلمه اليوم. CRMO نسي صار obsolete الحين. But this is the new name which has been allocated in the literature and all of these subspecialized people. So in adult age group, you will have Sapho syndrome or disease. In pediatric age group, you will have CNO. They are the same disease category, the same manifestation. If you biopsy the lesions, you will get 0 bacteria. And the management is not antibiotic at all. The only differential diagnosis except infection is Ewing sarcoma, because it gives the similar manifestation on X-rays. So it gives lamellated periosteal action, and that's why you see the elevated periosteum in distal femur. This goes as lamellated, like onion peel appearance of the periosteum, which is really dangerous. So if somebody sees the onion peel or multi-layered periosteal reaction, think about Ewing sarcoma. Except in those cases which you see more destruction in the bone inside with element of healing. In healing, you don't see it in sarcomas. You don't have time to heal. Destruction is continuous. But in infection or low-grade infections, there is a time to build up the osteoblastic activity, and that's why you will see patchy sclerotic changes. So in this patient, you will see sort of patchy sclerotic changes. This patient has sacroiliitis bilaterally with subperiosteal fluid collection, has multiple spine lesions, which is discitis or spondylitis, and these are the features for Sapho/CNO, multifocal. And this is another case from the literature, and you can see that the bone scan, distal metaphyseal region, showing that this is an infection-like changes rather than metabolic bone disease. And this appearance is the one which is really getting you worried. So if you see it frequent, it affects the clavicles with build-up of the periustery action and osteoblastic activity. You get worried that this one might be an evidence of sarcomatous changes. SAPHO, we know that it is in adult age group and manifests the same thing in the patient's skeletal system. We'll show you this case. This is, I think, 3 months ago we had it. And mandibles are affected with mild sclerotic changes. You will see that, okay, now it is changing. Bilateral, I'll show you, these are the sclerotic, patchy sclerotic areas in the mandible. And you see that mandible? It's all of it containing those sclerotic changes within the ramus and in the center. And this is like a beard. It's the whole mandible. The only differential diagnosis, if I see this one, is cherubism, yes, which is a fibrous dysplasia. So if you see this one, the magnognathia, big, so, and the widening of the intramedullary region, this is cherubism. This is the MR. You can see that the replacement of all of the bone marrows here with destruction of the cortices and also the cystic-like changes like the abscesses, involvement of the juxtacortical regions. All of these are showing the hyperplasia or osteitis. You see those cystic changes, involvement of the periosteum and adjacent adjacent soft tissues. So this one is even showing multiple lymphadenopathy in the posterior and anterior triangles. So take home message. If you have a patient which might be exhibiting signs and symptoms of sacroiliitis or spondyloarthritis, it's not only the differential diagnosis. Go more and search, especially if it is young patients. Think about CNO, chronic non-bacterial osteomyelitis, as a differential diagnosis for those patients, especially if there is another sites affected or recurrent involvement of different sites. Okay, any question for this? تفضل دكتور. Okay. The whole body MR is good for enthesitis, searching for the multiplicity of the disease. Bone scan is good in cases where there is increased osteoblastic activity. So if you have destructive bone lesion without, that means osteoclastic activity, will not be seen in bone scan unless there is an element of osteoblast building up. In cases of fibrous dysplasia, metastatic disease, all of these, they have increased activity of the osteoblasts. That's why حنروح ونسوي whole body bone scan. In these cases, I believe we will scan only the affected side each time the patient comes to you, especially if you are asking for MR. Why is that? Knowing the multiplicity of the disease doesn't show you or doesn't tell you which part is the active disease, number one. Number two, if you do whole body MR, the resolution of the images you are going to have is very, very, very low resolution. So you cannot say that there is an evidence of subperiosteal collection or juxtacortical soft tissue involvement unless it is really severe مثل الحالة اللي شفناها. So what I advise, if you are thinking about CNO or CRMO, SAPHO disease, go for localized affected site examination by MR. If you want to see the multiplicity of the disease, etc., I think bone scan is good and quick. Okay? طيب. Any other questions? طيب. We'll go for the third case. Patient, which is 53 years of age, polyarthritis for 5 months, significant limitations of joints, mobility. This patient had in his history previous malignancy, which is left leg melanoma, which has been resected. Then, after a couple of years, he had metastatic changes on a lymph node, where he was given chemotherapy for the second time. And then laboratory examinations, rheumatoid factor, and TCCB, all of them were negative. So this is the only thing which is really... this patient came with generalized aches, restriction of motion. These are the X-rays for the left hand. Any thought? From X-ray, is there any changes? Okay, I'll tell you something which is really very helpful. احفظوها مني. 5 things. مجموعة في قولك يرملون. وش يرملون؟ عشان ما تنسونا بس تربطونها. هذه حقة الإدغام ها. أي A B C D S. A B C D هذه معروفة والS تجي بعدين. فالA is alignment, B is bone, C is cartilage, D is distribution, and S soft tissue. If you want to evaluate the joints, شوف الخمسة هذه. وش السادس؟ Erosion? Okay, and I can convince you إن شاء الله مع C هذه تجي. Okay. So A B C D S ونخلي الإي احتراما للدكتورة موجودة إن شاء الله. So what we will see, if you want to evaluate any joint, especially hands and feet, go through these. A, alignment. هل في عندنا any displacement, ulnar deviation, subluxation? There is no subluxation, so it is the alignment. B, bone density. Is it increased? Is it decreased? Is it normal? C is the cartilage. الكارتلج هو السبب ان احنا نشوف الجوينت سبيس هنا. If the cartilage is eroded, gone, the joint space will be reduced. If there is any joint effusion, there will be pseudo widening of the joint. If the cartilage is thickened, like cases of acromegaly, it will be widened. Okay? So if there is any element of joint space narrowing / widening, you should comment on these. If there is any erosions of the cartilage or not, articular surfaces, you should comment from C. D, distribution, is it proximal or distal or all? And S, soft tissue. Is there any soft tissue swelling? Is there any soft tissue calcification or soft tissue loss? Okay? So in this case, the osteopenia is not really limited to periarticular osteopenia alone, but this is a generalized, almost generalized osteoporotic changes of osteopenia. What does that mean? That the disease is very severe, preventing the patient to move his hand, and this is disuse osteopenia. Gives you indirect sign for the severity of the disease. So now we have joint space narrowing, yes. Carbo-metacarpal joints, they're very much narrowed. Radiocarpal joints, very much narrowed. And also erosions in the second metacarpal bone, juxtacortical and going towards the center. That means this is really severe manifestation of a disease. These manifestations, they are typical for RA, rheumatoid arthritis. So this is a disease of rheumatoid arthritis manifestation in this hand. Still disease is something which is really systemic, can be. Erosions are not really that much common with the Still's disease as but narrowing of the other joints, metacarpophalangeal joints, no significant features of a systemic involvement, hepatosplenomegaly, others else. So these are not really supporting. But what I believe that this is a rheumatological manifestation. Okay? We'll go more. So this is the same almost, erosions at the basis of the fifth metacarpal bone. The base of the fifth metacarpal bone is typical for rheumatoid arthritis as well. The patient had X-ray of the pelvis, unilateral sacroiliitis, destruction of the L5S1 as well, with subchondral sclerosis, which is endoplate sclerosis. This is the MR, coronal stair, T2 fat separation, which is like the stair, which is fluid-sensitive sequence, and the coronal T1. So we have thickening of the synovium, joint fluid, and also bone edema like erosion at the distal corner, radial corner of the lunate bone. So these are all telling you that this is a synovitis features. The extensor tendons showing tenosynovitis, especially compartment number 2, extensor carpi radialis, brevis and longus, surrounded with the fluid. There is even a limit of synovitis around the ankle joint. So he has also other manifestation for polyarticular disease with evidence of even tenosynovitis. So, summary, the patient is 51 years of age, polyarthritis, synovitis, erosions, labs are negative, rheumatoid factor is negative, but he has a history of metastatic melanoma and got this medication. Any thought? So, nivolumab is something which is really chemotherapy, which is really used in many of the malignancies. I will list them now. This one is drug-induced rheumatoid arthritis, seronegative rheumatoid arthritis. So because by this medication. So if you have a patient, this is the take-home message, who has malignancy, has been treated with chemotherapy, and then presented with systemic disease or systemic arthritis, think about drug-induced rheumatoid arthritis or seronegative arthritis or inflammatory arthritis. نرجع. نرجع إن شاء الله ما عندنا مشكلة. PIP is involved. لا, DIP is not.
Because
not
if
there.
the DIB involved is not consistent with seronegative or seropositive RA. Never ever the DIB involved in RA.
This is interferential. This is PIP.
No, I want the DIP. Do you have
DIP is not there. No, it's not included.
But because if you have a DIB involvement, this doesn't go with the drug-induced rheumatoid-like. This is my opinion, personal opinion.
This is an.
It goes more with the still disease. Fasciitis, carpal bone, erosion, soft tissue, joint space narrowing, still disease. I will look for the ferritin. If the ferritin high, it confirms my diagnosis.
Okay. Now we'll نحاول شوية نقنعك يا دكتور بس أعطني فرصة ها إن شاء الله. So what is إحنا ما خلصنا لها الحين. This is the medication which Opdivo, which is really important to know. This is one of the commonly used chemotherapy. And these are عشان الواحد يحول ماني شايفه كويس فميتاستاتيك melanoma, small non-small cell carcinoma of the lung, renal cell carcinoma, advanced one, squamous cell carcinoma, even hepatocellular carcinoma, rectal carcinoma, all of them has been treated or one using this medication. So if you are working in a center which is dealing with sarcomas, malignancies, and they're using lots of these medications, just keep this point in the back of your brain or your memory that it might be associated with this lesion. What has happened to this patient? نرجع شوية بس معلش. Even a lymphoma has been using this medication. The severity of the arthritis hasn't been related to the dose or for the time, which is the period which was used. So it hasn't been really studied very well. So this is an area for research if you are having sort of a medication like this. So now, by MR, can we differentiate RA or inflammatory arthritis from this disease, which is drug-induced arthritis? You cannot differentiate because all of them, they are inflammatory arthritis. So synovitis, what I meant. So all of them the same thing, okay? So it's almost copy and paste. These are two different patients showing almost similar manifestation of inflammatory arthritis / synovitis. This patient had been treated with steroid and DMARD and completely resolved and never came back with the similar manifestations of synovitis. So this is one of the points which is really supporting that it is an inflammatory disease, drug-induced, and you can see the difference between the abnormal in May 2019 compared to January 2020. So you can see the difference between these two MR, complete resolution of synovitis, tenosynovitis, and also even the Pannus disease, distal radioulnar joint involvement. So there is an entity called drug-induced arthritis. So just keep this one in your management. So the risk of seronegative arthritis or the rheumatoid arthritis is really much preventing the patient from having the normal exercises, normal daily work. So these are the things which is really need to be known. And the most important one, which yesterday in both lectures I mentioned, that early diagnosis is our cornerstone dealing with patients. So we try to diagnose the disease as early as possible. We don't want to wait until irreversible changes happened. I think الحين احنا تجاوزنا الوقت. الله تفضل يا دكتور.
Checkpoint inhibitor induced arthritis usually associated with high autoantibodies. Rheumatoid factor usually be positive, NCCB positive, even autoimmune thyroiditis usually elevated if this arthritis is related to the drug, the checkpoint inhibitors.
Yeah.
The second point that why is this case not paramalignant arthritis? Usually, many cases are diagnosed as rheumatoid arthritis and they may be secondary to lymphoma caused arthritis. The disease itself, not the medication itself. This is my two comments.
Yeah.
Especially our prof said there is abnormal site of erosion not related to the RA. DIB involvement, our thinking must be go far away from the rheumatoid arthritis, even arthritis induced by medication.
Okay. If we are just limited to RA, we can just go for inflammatory arthritis, drug-induced inflammatory arthritis. But because of the going towards a distribution of proximal with the severe manifestation polyarticular changes, with tenosynovitis, we thought about rheumatoid arthritis, which is drug-induced inflammatory arthritis أحسن عشان ما يكون عندنا الخلاف في السب categories. الأمر الثاني بالنسبة للcheck point inhibitors. I don't have that much of ideas about what are these showing on the blood or serum evaluations of antibodies. So we need to study this region. So now we ended up of one category which is really important. Paraneoplastic inflammatory arthritis is a possibility. But if you have a patient which has been disease-free for 8 years and then recurrence with metastasis happened, and post management with this medication, those events has happened, you should relate those diseases as drug-induced. And the second point is that the time they treated it as inflammatory arthritis has been resolved. So I think that we can say synchronous, parasynchronous, or metasynchronous arthritis, paraneoplastic arthritis. All of these can happen, definitely. جزاك الله خير. Good points. احنا رايحين نقرا كثير على الcheck point inhibitors. Any other interaction؟ عشان آخر يوم وواحد قال لي ترى تعبت لي 3 أيام أنا الحين شغال. تفضل يا دكتوري.
Sometimes there is confusion between the lesions of CRMO and infarcts, especially in pediatric. If you have a sickle patient, you have multiple infarcts. So how would we differentiate between the two?
Okay. And the infarctions, definitely, they are intramedullary infarctions. And we have a grading system for the infarctions, intramedullary infarctions. The typical manifestation of intramedullary infarction is that showing serpentine type of outlines. These are naturally seen in CRMO or infection. Infection as osteomyelitis with Brodie's abscess, it will be very well defined spherical type of collection. CRMO, it will be multiple small foci of pockets of fluid. So all of these would give you the appearance of definitely something away from the AVN or intramedullary infarctions. The only thing which might be debatable is that the periosteal reaction and juxtacortical soft tissue involvement. Sickle disease, acute sickle incident would cause element of periosteitis and collection in the subperiosteal regions. So you'll see similar appearance of this. So the only differentiation that you go for the intramedullary changes and then you can correlate them. Okay? So if you have only cortical, subperiosteal changes, you cannot definitely differentiate between CRMO/CNO and the intramedullary bone infarction or sickle cell disease, a crisis, acute crisis. So now the only differentiating point, intramedullary signal changes. Okay? By the way, if you have any patient with sickle cell disease in an acute crisis and you found those collection, please do not try aspirating this. Never. Because these are serous fluid. There is nothing telling you that this is an infection. So it is not infection, it is not abscess formation, it is just serous fluid collection. So it is not advisable to stick your needle in patients with sickle cell disease and subperiosteal bone collection. جزاكم الله خير. شكرا جزيلا.